Thank you. So my name is Aaron Sissel, and I'm going to talk about approaches to, oh, by the way, yeah, I've got the video off. I'll turn it on for a second. I'm going to talk about approaches to assessing worker mental health using existing population health data. And I'm pleased to be a part of this program today. I'm humbled by all the great speakers there have been already. I'm a longtime employee of NIOSH. I've been with NIOSH for more than 3 decades. A lot of that time I was studying hazards and health outcomes in all industries. And for the last 5 years, I've been with the Spokane Mining Research Division. I voluntarily transferred because I love the Western United States and wanted to get back out there. I had been in Cincinnati for many years for NIOSH. And the other thing that's different about me is I started my career as an industrial hygienist, did that for about the first half of my career for NIOSH, studying hazards in the field in a variety of industries. Then I went back to school, made a conscious decision to basically switch occupations and study occupational health epidemiology. I'm now an epidemiologist, but I'm also an industrial hygienist, of course, still. So I'm a hybrid individual. And let me video. I'm having a hard time advancing for some reason. Don't understand that. Oh, I guess I just click. I'm sorry about that. Apologize. So objectives today, this is a real high level look, not a lot of detail. And I also wanted to offer a disclaimer that I'm not a behavioral scientist. I'm not an expert on mental health. My expertise is more general in occupational health. I would say I'm an expert on using existing data sources for occupational health surveillance and analyzing that data by industry and occupation. And we depend on the coding of industry and occupation to analyze data. So I'm going to talk a little bit about the difference between mining and oil and gas extraction, the subsectors, social determinants, psychosocial hazards, suicides and drug overdoses, what the data shows us, using indicators to assess workers' mental health with the population data, some preliminary findings, and some lessons learned. And it'll be a high-level look. So I am in the mining program, which is completely separate from the oil and gas extraction research program. We have a project called the Evidence-Based Framework for Improving Miners' Health. And it's essentially about leveraging existing data, using health data, to compare miners' health to other workers. And some of those other workers are oil and gas extraction workers. CDC systems are primary data sources for this health behavior, and vital statistics, death data in the adult population. And on this project, we have a team, a multidisciplinary team. I've been leading this project for the last 5 years, and it's going to have a new version later this year, and we're going to transition to a new team lead. And epidemiology, I would say, is probably the primary discipline, but industrial hygiene, statistics, health communication, and behavioral science are also very important and really essential to do what we're doing. So first, a little bit about the National Occupational Research Agenda. Some of you know about this, but it's a good reminder because I kind of focus on this stuff, analyzing the population health data. So NIOSH research program and our national agenda is based on 10 industry sectors. And these come from 21 national North American Industrial Classification System, NAICS, sectors, and there are a regrouping of those. And mining and oil and gas are both in the mining sector for NAICS. However, they are separate NORA programs, separate research programs in NIOSH. And one of the reasons for that, I believe, is that they are separately regulated. Oil and gas extraction is regulated by OSHA, and mining is regulated by the Mine Safety and Health Administration, MSHA. And the reality is, if you're in mining, except oil and gas, you get much more frequently inspected by the Department of Labor. I would say a frequency of probably around 1,000 times greater, maybe even more than that. You will be seeing MSHA 4 times a year if you are an underground mine, and 2 times a year if you are a surface mine. So moving on, a little bit more about this difference. So we have the mining sector overall as defined by NAICS, and it's a small industry, has about 600,000 workers. And then we have mining except oil and gas, about 200,000 roughly. And then there's 2 other subsectors in the NAICS system: oil and gas extraction and support activities for mining. And Department of Labor, Bureau of Labor Statistics, these are considered to be separate subsectors, the latter 2. However, we've looked at this with other data sources and the BLS data itself, and it can be seen that the vast majority of workers in support activities for mining are doing oil and gas extraction. In fact, it could be as high as 97% of them. So when we analyze data, at least I do, group these 2 subsectors together as oil and gas extraction. So that's a little bit about industries that we're focused on in the mining program and in the oil and gas extraction research program. But we both have a lot of common interests. These 2 subsectors, these 2 NORA sectors, have similar hazard profiles. There's a lot of similarities in the workforce between the 2. And so we're both concerned about work and the social as a social determinant of health. This is a conceptual model which may be helpful. I didn't originate it. It's from Robert Wood Johnson Foundation. But essentially, there's 3 major things that make work very important: the physical aspects of work and the workplace and the exposure to hazards, the psychosocial aspects of work and how work is organized, which leads to stress. The physical hazards, by the way, and the physical aspects are the classic occupational safety and health that NIOSH was founded to address. But obviously, we've expanded our scope greatly since the 50 years ago. And then the third aspect of work as a social determinant are work-related resources and opportunities. And I put these with a green circle around them because many of these things in this area are beneficial and very important to health, such as ability to obtain nutritious foods, support yourself, have health care, medical care, etc. So all of these things influence both physical and mental health. And managing stress and mental health, when we talk to folks in the mining industry, probably the single greatest concern is exposures to silica. One of the reasons is that MSHA has announced that they're going to revise or come up with a new standard for silica exposures. And so everybody's preparing for that. But almost equal to that now are concerns about mental health in the mining industry. It's recognized as a very important issue and as a problem that needs to be addressed. And so the industry is thinking about, and we are too, psychosocial hazards at work. These are some of them: unemployment, fatigue, which was mentioned, long shifts, wages or lack of them, the benefits. The benefits obviously are beneficial to health, but if they're limited or lacking, they can negatively impact health. Transportation, and there's working conditions, of course, and industry and occupational, cultural, and geographic differences with different industries. So I'm now going to transition very quickly into talking about, well, what do we know about suicide rates among workers? I've been involved with looking at this since our project began. looking at miners' health about 5 years ago. And the paper that's cited here with the QR code is one that I co-authored. And we looked at suicide rates using CDC vital statistics. What we found is that males in the mining sector and females in construction and extraction occupations have the highest suicide rates among all industries and occupation by sex. And in the year 2017, 7 times more working age persons died by suicide, 38,000 people, than from fatal on-the-job injuries. So fatal on-the-job injuries are now dwarfed by deaths among workers that happen outside of work, but that may be related in some way to their work. Suicides overall have increased 40% in the US since the year 2000. If that wasn't enough, we also have an epidemic of drug overdoses in the United States. And this is colleagues at NIOSH that used, again, CDC surveillance system data to look at this. Between 2007 and 2012, workers in extraction occupations had elevated mortality for both drug and prescription opioid overdose. And in 2021, there were more than 100,000 drug overdose deaths of all ages in the US, a 15% increase in 1 year, as in the previous 2 years. This is really astounding that this has become one of the major causes of death in the United States. And there are disparities among these deaths, the rates by age, race, ethnicity, and other factors. And of course, work is only one factor. So a little bit more about analyzing suicide rates by industry and occupation using vital statistics. The study I mentioned earlier that's completed is available. It was published in the MMWR. That was using the National Violent Death Reporting System, which has both homicides and suicides that CDC has maintained for a number of years. It was 2016 data collected. It was 32 states who collected usual and industry and occupation for people who died. In progress, we have an update of this using 2021 data that will hopefully be published by the end of this year using a different data system that CDC maintains and works with the states on, called the National Vital Statistics System, NVSS. It's bigger, it's better. We have 49 states collecting usual industry and occupation for people who died. So the industry and occupation are just critically important variables. We call them demographic variables, like some of the other demographics you're familiar with, such as age and sex and race, ethnicity, because they help us explain what's going on with these outcomes. So moving into a little bit about what we did see with this data. This is from the paper that has been published that you can find, and I can share it with anyone that asks or put it in the chat. So first we looked at the suicide rates by industry sector, and these are rates per 100,000 workers. Not all groups are shown here. I showed some of the highest and some of the lowest. And you notice that the top row is all workers. So, and there's a big difference between male suicide rates and female. And this is across the board, even for people who are not working. So you can see here that the rate for males is about 3 times higher than for females. So we stratified by sex. And what we found is that mining and oil and gas extraction, so everything combined into the mining sector, we didn't have enough data to break it down, had the highest estimated suicide rate of any industry. And next was construction industry. And then you can see how it breaks down further. And down at the bottom end, lowest, education services and finance and insurance. But the difference between males and females is consistent across industries. When we looked at it by occupation group, another way to look at it, again, Construction and extraction had the highest suicide rates for both men and women. Most of that particular major group is construction, by the way. So that's sort of a combination of mining, oil and gas, and construction. And down at the bottom, again, education occupations and business and finance operations occupations. So it does seem that work has some influence here. It's one factor. We're not trying to say that work causes these differences, because we were only able to control for sex in these analyses, not the other demographic differences. And people self-select into different occupations. So part of the differences can be the different demographics of these groups. That can be a big part of it. But this is showing the burden in these different occupation groups and industries, which is important to understand. And I think we all agree mental health is an important part of worker well-being. Poor mental health is a major source of disability. Suicide, the worst outcome, in a way, is the tip of the iceberg, because what's more common are mental health conditions, mental illness, sometimes temporary, can be chronic, suicide ideation, depression, anxiety, and mental distress. And I think these things are so common that all of us have either experienced them ourselves, or we have a family member or know someone that has. It came home to me personally this year. A longtime friend of my daughter, who's in her early 30s, a friend from high school, a male, committed suicide this year. And I could just, understand personally the impact on her and the impact on us who knew him. And, so these effects just multiply in our population. When somebody has a serious mental illness or a person commits suicide, it has a ripple effect on many other people. So what about looking at mental health indicators? We've been using the CDC's largest health surveillance system. It's an annual survey called the Behavioral Risk Factor Surveillance System to analyze workers' mental health by industry and occupation. It's a great data source, very large survey. More than 400,000 people are interviewed per year. They're selected randomly. CDC and the states do this together, and there's an industry and occupation module that's optional that was added by NIOSH. It's got a long history. Questions are changed very infrequently to maintain consistency. It's got a complex survey design, and the respondents are weighted to adjust for the sampling design. And so they represent a certain number of people in their state. And there are mental health indicators in this system, ever diagnosed and current self-assessment. And I'll move to that quickly here. So here are the indicators. One is people are asked, have you ever been told by a licensed healthcare professional that you have? And then they ask about a lot of conditions. One of them is diagnosed with depression. Then there are the self-assessment indicators. Mentally unhealthy days. How many days in the past 30 days has your mental health not been good? And then from that variable, we can calculate several indicators. Frequent mental distress means greater or equal to 14 days, not good. Extreme mental distress, 30 of the past 30, not good. And mean unhealthy days for groups. And overall, we have big challenges using this population health data. It's a great data source, a great health surveillance system. Sample size for 5 years was 452,000 workers, which is a tremendous sample size. But then look at how much a part of that was the mining sector. It's tiny. And it's particularly tiny for females because both mining, except oil and gas, and oil and gas extraction are primarily male industries. So this is a challenge. Here's some demographics that we get from the BRFSS. That's one of the valuable things it can do. And we can see here that mining and oil and gas extraction, they're more male than other industries. Mining is older than all other industries. Oil and gas extraction has more Hispanic workers than all other industries too. And mining has more white non-Hispanic workers. And both oil and gas and mining have a lower educational attainment overall than all other industries. And on the mental health outcomes, here's what we've found so far. This is preliminary results. Hopefully this will also be submitted for publication later this year. That's the plan. We can see that for mining on ever diagnosed with depression, it's surprisingly lower than the other groups. And remember, the mining sector had the highest rate of suicides. So why could this be? Well, to be diagnosed, you have to seek care. The person has to seek care to be diagnosed. On the frequent mental distress, it does look like that mining and oil and gas extraction are a little bit higher than all other industries, but there's quite a bit of uncertainty in those estimates you can see with the confidence intervals. And then on extreme distress, we didn't have enough precision to report for mining, but it's higher for oil and gas extraction than for all other industries. About 5% is our estimate of the people interviewed said every single day in the last month, my mental health was not good. And then mean mentally unhealthy days for the entire group, a little bit higher according to the point estimates that than all other industries, but these differences were not significant. And then for females, again, this is looking at the same thing for females. On the frequent mental distress for mining, women in mining reported actually lower frequent mental distress than all other industries. And the mean mentally unhealthy days was lower. But in oil and gas extraction, women reported higher mean, well, for the group, it was higher mean number of mentally unhealthy days. The dashes mean that we could not report the estimates due to inadequate precision. So unfortunately, we're limited by sample size. It's quite a small sample size, as you can see, for both mining and oil and gas extraction, only 120 and 250 people. So limitations of these indicators, they're very useful. We think it's important to publish them and that people in industry and occupational safety and health see them, but they are self-reported and they actually may be underreported. There's potential biases, recall and social desirability bias in answering questions in a telephone interview. And a clinical diagnosis of depression does require that the workers seek care. So if workers don't seek care in mining, for example, they're not going to be answering yes to the question. Usually, it's not possible to report estimates for detailed industry and occupation groups with this data. That's a limitation for us. And misclassification of industry and occupation is possible. So that's a lot of information in a very short time. It's just kind of a quick overview of what we're doing. Here are some resources that are available. These are all links in this slide to where to get more information from NIOSH and from CDC, and also for the Colorado School of Public Health has good information about these things. So lessons learned, there's more that we don't know than what we know. A lot more research is needed. Suicide rates by industry and occupation are useful for showing trends and targeting prevention. The self-reported indicators are useful, again, to identify patterns among industry and occupation groups and sort of the amount of burden there. And there are good resources available now to assist employers. We don't need to know everything to take action. And that is it. And I appreciate your attention and feel free to contact me. And this QR code has a link to the Miner Health program.
Great, thanks so much, Aaron. Do we have any questions?
Let me see.
Aaron, I was about to say, there's a question in the Q&A box
Perfect.
from Francisco, if you wanted to take that, because most
Yeah.
of the individuals who are in the audience can't unmute, so.
Okay, yes, I see there's a question, the NVDRS records, does it, the question is, does it record workers that take this route, commit suicide when they're away from work or on days off? And does it also consider intermediate family as related? So in answer to the question, there's limited information about each person who died in the system. And we don't have all their demographic information, and it does not indicate whether the person died at work or not at work, but generally it's not at work. You know, most suicides do not occur in the workplace. I would say that's fairly rare. So yeah, that's why the connection to work is kind of inferential in sort of looking at the patterns, and we have to be cautious about interpreting the data.
Aaron, I just saw another question pop up. Significant differences between below ground miners and surface miners?
Well, great question. We don't have sufficient, you know, as I indicated, even with this gigantic health surveillance system, the industry's small, and we just don't have sufficient sample size, I think, at this point in time to look at that. Possibly if we aggregate more years, we might be able to, but then it becomes less useful if you are aggregating like 10 years. So it's a great question. I've thought about that myself because I've been in big underground mines and I've also seen surface mines. And certainly, I think there's additional stressors underground in a big mine, for example, a big metal mine, in the darkness and just the feeling of isolation and knowing that you can't get out quickly. If you go into the mine and you forgot your lunchbox in your car, you're not going back. It's a huge deal to get back out. And it's just not done very often. So that in itself could, yeah, they can be different.
And then I scrolled up and we had a question in the middle of your presentation, Aaron. What does the data and the percentages stand for? And I'm not sure if the person who asked that question can provide a little bit more context or maybe a reference back to a slide.
That question came up when he was talking about, I think, the 95% confidence intervals that Aaron was showing in the percentages or in the parentheses.
Okay, hang on. Let me just yeah, so I probably not, well, I guess I can try resharing real quick here. Do you see a slide now?
Yes.
Oh, that's the wrong one. I don't know how to go back with, oh, here we go. Okay, so yeah, the percentages are for the entire group. So you can see the number of people that were interviewed is the first row for each one of those groups. And then it's the percent who said yes. And then the confidence intervals are the 90, you know, the other two numbers in parentheses are the 95% confidence interval for the estimates. I hope, hopefully that addresses it.
And then we had two more questions pop up, Aaron. The first one, depression is one type of mental illness. Are there studies or resources for other types of mental illness? Yeah,
that's another great question. And, you know, I'm not an expert at all on mental illness, as I said earlier, but I think with the population health data, the measure that's been used most frequently over the years by CDC is the frequent mental distress indicator, which is based on self-report of mentally unhealthy days in the last 30 days. There's also a question that asks about physical health in the last 30 days. So there's really 3 questions on the survey that address physical and mental health. Those 3 or 4 together are called the health-related quality of life indicators. And there's a paper that was published on that a few years ago by Taylor Shockey. I was a co-author on that paper as well, which we looked at industry and occupation differences for health-related quality of life. And in that one, we were able to control for potential confounders, and you still find differences between industry and occupation groups. So when we are able to control for the demographic differences and we see differences, what my conclusion would be is there's something about work that's making a difference, and it's unmeasured things. Industry and occupation are just our surrogate for the exposures that are happening at work. Hopefully that kind of helps in thinking about it.
And then the last comment was thinking about the impact of vitamin D and how that can play into those miners working underground.
Yeah, well, vitamin D we get from exposure to sunlight, right? And so, you know, if someone has a deficiency, if they go to their doctor and they're deficient in vitamin D, you know, they could take supplemental vitamin D. I don't think we have, you know, data on that addresses that, but I do think that to work underground, you know, 10 to 12-hour shifts, I've been in some large underground mines. It takes a certain kind of person to do it, I believe. It's very challenging to be, you know, a mile underground for an entire work shift, or even your breaks or your lunch, you're in that same environment. So it's not everyone can even do that kind of work. But what I've been told by folks that I've talked to in the mines is that people who do that type of work, the self-selected group that do it, they like the work. They enjoy doing it. There's people that do it for decades. So it's not an easy thing to answer. What is the effect of working underground? People that don't like it usually quit on the first day or in the first week. That's what I've been told.
Great, thanks for that insight, Aaron. We've got a lot of
Thank you
great
very much.
questions. I think we need to move on just to keep ourselves on track, but we should have some time towards the end if anyone would like to share a thought or comment to wrap us up here.